We heard the story of Solomon, and we heard the struggles and the obstacles that he and his mother had to fight for. That when he came back to Belgium, no one really wanted to offer him rehabilitation because he was too severely damaged. And that is something which we see so often. And even patients with less severe damage are not always accepted into rehabilitation facilities. It's things like that, organizational structures, that I am convinced, after having worked for more than 30 years as a neurosurgeon treating patients, it's such organizational aspects. If we can improve them, that'll give a major advance and improvement in the treatment of all patients, probably much more than the improvements that we seek to reach in the clinical phase in intensive care medicine. So I would like to give you a short summary overview of TBI and its many causes. Do you want me to come up there and do it? TBI is a global disease. I maybe need to turn that one on first. Okay, that's it. That's a way to shut me up if I take too long. Just turn on another mic. TBI is really a global problem, and I'm very glad that we're here with so many people from around the world sitting at the table. About 80% of all publications arise from Europe, US, North America, Japan. More than 80% of trauma occurs in other parts of the world. So we should not look at TBI with our eyes from highly developed countries. We should take a broader perspective and try and improve it. And those broader perspectives mean collaboration. And we're very fortunate that the funding agencies, European Commission, the NIH, the CIHR, and others are now collaborating in INTBER to promote the care for TBI, really working towards concerted efforts and global collaborations. And the footers under some of my slides, you'll find them in the Commission on TBI of the Lancet Neurology, the occasion for which we are really here today also to present it to you, and we're very happy to have the editors present. So this gives a little bit perspective of the epidemiology across the world. 50 million new cases per year, as we already heard. What I would like you to see on this map is the large gray zones. Those are the zones where we do not have accurate data. Those are the countries where TBI is the greatest problem. It costs the community more than $400 billion per year. When we look within Europe, and this is work from Marek Maiden from Trnava, and he looked at Eurostat data. And the Eurostat data show an overall pooled incidence of around 287 per 100,000 people per year, which is a lot. But if you look at this graph, you will see some countries with a very low incidence and some 10 times higher. Which are these countries? I know you can't read it all. Portugal, Spain, and Italy. And up here is Germany and Austria. So the incidence in Germany and Austria is 10 times higher than Italy. I wish it were true for my Italian colleagues. This is a methodological problem in the data capture and the data analysis. There's much to be improved there, yet these are the data that politicians base their decisions on. if we cannot trust the data, we need to do something about it. If we look for a broader perspective between the US and Europe, and you adjust for the population differences, the number of new cases in the US is about double that for Europe. Conversely, the number of hospital admissions in Europe is 3 times as high compared to the US, expressed per 100,000 population. We don't understand those numbers. If anything, I would have expected more admissions in the US because of a more defensive approach. But that is not the case, at least not what the official figures from CDC, from Eurostat tell us. I already mentioned the 400 billion US dollars. When you relate that to the total global economic output, it means that 1 in every $200 is spent either on the direct costs or the consequences of traumatic brain injury. And those are huge sums of money. What many of you may not be so aware of is that TBI is not an event, it's a process. There's a risk of long-term disease, dementia, Parkinson, epilepsy, and ALS. And there's an increased risk of dying many, many, many years after TBI due to a variety of factors. So it's a process. Sometimes, in some patients, a lifelong disease. It's a very different types of diseases with multiple faces, as illustrated here on some CT scans, diffuse axonal injury, typical of the type of injuries that occur in road traffic incidents, actually as Salomon has had. The contusions we are seeing increasingly in elderly patients who fall down the stairs or fall sometimes under the influence of alcohol. Epidural hematoma is one of the emergencies in neurosurgery where you really need to operate as quickly as possible. And this is an MR scan tractography showing the brain of a patient 1 week after injury and 6 months later. And that shows you the loss of white tissue fibers over time. This comes from Jeff, my American colleague who's here with us. And Jeff says, we'd classify TBI into mild, moderate, and severe using the Glasgow Coma Scale. Now, the Glasgow Coma Scale is an excellent scale for monitoring individual patients. And the godfather of the GCS, Sir Graham Teasdale, is here with us today. But for purposes of classification, just splitting TBI into mild, moderate, severe is pretty crude, certainly when you compare that to how we approach classifications to cancer. So there's room for improvement, for better characterization. The chain of trauma care, I mentioned it already, there has to be continuity. If things are done poorly initially, you have lost the battle already. No matter how excellent the care in the acute phase can be here, if it's not consolidated with post-acute care, you lose these benefits. It's this structure of care, and there are disconnects everywhere in the world, also in our countries, as we heard. Those disconnects need to be repaired. And all the questions we have along the chain of trauma care need to be addressed. That is something which we are doing within CENTER-TBI, the Comparative European Neurotrauma Effectiveness Research, supported by the Framework 7 program, large-scale project. We aim to improve characterization. We aim to identify best practices with comparative effectiveness research, making use of the existing differences which Hester will be telling you about. So as of a few days ago, We now have more than 5,000 patients with detailed data collection. The target was 5,400, so we're nearly there. We have more common data, registry data, the basic in-hospital data up to discharge, on over 20,000 patients. Our Chinese colleagues, Professor Zhang and Dr. Gao, have collected data on over 13,000 patients with TBI across 60 centers in China. And our Indian colleagues, who unfortunately could not be present, have only recently started, but already have 2,500. These are numbers where you can meaningfully address aspects of structure of care. So this offers huge opportunities. Overall, what we aim to do is improve outcome by three main pathways. Pathways of improved characterization, more accurate diagnosis, actually precision medicine, that concept, leading to more targeted treatment, also more targeted prevention. Making use of the heterogeneity, the differences, with comparative effectiveness research to identify best practices, and importantly, improved prognostic models and quality indicators to benchmark the quality of care. So that's three different routes which hopefully will lead to improved care for TBI. We cannot take them as clinicians and researchers alone. This has to be collaboration with the policymakers, with funding organizations, with patient organizations. Only together can we really make a difference. Thank you very much.